in periodontal or implant surgery is very important factor in wound healing. The main purpose of suture is passive adaptation of the flap margin and mechanical stability of the flap for wound stabilization. There are three patterns to position the flap margin: everting, inverting, and oppositional. But in periodontal or implant surgery, everting suture patterns are used because the implant areas often require dispersal of tension forces along the wound closure line. The aim of suture are wound closure, hemostasis, maintain the blood clot, adaptation of flap to bone or root surface, and fixation of the graft or membrane, and secure the visibility. There are four essentials for suture: needle holder and tissue forceps, suture materials, and scissors, that the tip of the scissor is slightly curved. Now let's review the suture material. There are observable and non-observable suture materials, and also braided and monofilament materials. How do we choose the suture materials? Because the purpose of suture is to maintain the structural integrity during the wound healing, the suture materials should be maintained longer in root surface than alveolar bone, because there are differences of the blood supply. And if you want to maintain the suture material longer, monofilament suture materials are better, because much plaque can attach to the braided suture materials. Every suture material reveals the information of the needle on its cover. 12 to 30 mm of needle length is suitable for mucogingival surgery, and longer needle, 17 to 18 mm, is suitable for periodontal flap surgery. Cutting edge can be tapered, reverse cutting, and round. Reverse cutting edge has high efficiency. That means it can pass the flap easily, and it does not make flap tearing when we pull the suture make the knot. And needle diameter is matched the suture size to minimize the tissue damage. Choosing finer suture diameter may reduce the trauma on the tissue, but the difficulty of the skill may increase. The silk is from natural, non-absorbable, and braided material. We usually use silk in the extraction socket. The silk is strong, easy to make knot, and cost-effective. But the plaque can attach the silk very easily, so the tissue reaction is quite bad. Nylon is most widely used in periodontal and implant surgery. It's a synthetic, non-absorbable, and monofilament suture material. The plaque cannot adhere to nylon, so the tissue reaction is good around the nylon. And the tension and tissue penetration ability are advantage of nylon. But nylon is quite hard to make knot and more expensive than silk. Another commonly used suture material is Vicryl. It's a synthetic polygalactin absorbable material. The coated Vicryl is maintained more than 3 or 4 weeks, but uncoated one will be absorbed in 2 or 3 weeks in the oral cavity. EPTFE suture, also called Gore-Tex suture, can be used in membrane suture. Like in this picture, Gore-Tex suture material is expensive but has very good tissue reaction, so I sometimes use this when I need to suture the barrier membrane underneath the flap. I usually use 5-0-ethylene for the implant surgery or periodontal surgery. This is monofilament non-resorbable suture materials and has excellent strength and less tissue reactivity. These kinds of monofilament suture, like nylon, ethylene, Deflon, are more difficult to handle or make tie. Because there is little friction in the suture material, 4-0 nylon suture can irritate or abrade the oral mucosa around the wound site, so I recommend to 5-0 nylon or ethylene suture. So how we make perfect suture? These are main principles. Pierce the flap surface with the needle perpendicular to the flap. and the piercing the point should be located 5 mm away from the flap margin. The suture should go from movable tissue to non-movable tissue, and do not touch the alveolar bone or tooth surface to prevent the needle bend. Surgeon's knot is commonly used method for making knot. This knot does not easily break and well maintained even with monofilament suture material. Surgeon's knot is formed by 2 throws of suture around the needle holder and the first tie and 1 throw opposite direction in the second tie. The knot should not be placed at the insertion point and incision line either. The choice of knot depends on the suture material. For example, if you use nylon, you'd better choose surgeon's knot. And excessive tension should not be applied. The simple interrupted stitch is a suture technique used to close a wound. It is the most commonly used technique. Placing and tying each stitch individually is time-consuming, but this technique keeps the wound together even if one suture fails. It is simple and easy technique. Let's look at the simple interrupted suture and the surgeon's knot. The needle should pierce the flap with right angle. Buccal flap first, and then go to the lingual flap. And this is how to make surgeon's knot. 2 throws of suture around the needle holder on the first tie, and 1 throw opposite direction in the second tie. And then cut the suture material. Anchoring suture uses the tooth, implant, masticatory mucosa or connective tissue of the vestibules like an anchor. Needle placed at the lingual area of the flap adjacent tooth, anchored around the tooth passed beneath the opposite flap and tied. It is useful to close a flap mesial or distal to a tooth, for example, distal wedge procedure, and close the facial and lingual flaps and adapt them tightly. This is anchoring suture and it is useful in distal wedge procedures. Pierce the buccal flap first, and the suture material should go around the adjacent tooth to make an anchor. And then pierce the lingual flap again. Then we can achieve the anchor at the adjacent tooth and make a knot. You can push the flap to the anchor side. Next is continuous suture. The main advantage of the continuous suture is the speed, because we just make 1 tie in the long wound area. But main disadvantage is that if the suture breaks in one point, the flap may become loose or the suture may untie from multiple teeth. The continuous sling suture is used to adapt the buccal and lingual flaps without tying the buccal flap to the lingual flap. The teeth are used to suspend each flap against the bone. Continuous locked suture make wound margin approximation with successive loops. The advantage of continuous locked suture is useful for long edentulous area, and it has the advantage of avoiding multiple knots. There are friction points, it means locks along the suture, to reduce the tendency of suture loosen when placing the rest of the suture. Thus, the locked stitch help to hold the previously placed portions of the continuous suture tight. Unlike continuous suture, if one suture breaks or fails, the flap may keep the position during healing because of the locks. Mattress suture is a special type of suture and is described as horizontal and vertical. It's an indication in cases where strong and secure reapproximation of wound margin is required. They also allow for good papillary stabilization and placement. This is vertical mattress suture. I usually use this suture technique when GBR is done because this technique can help everting the flap margin. This is how we do the vertical mattress suture. The needle passes at two levels, one deep to provide support of the wound surface at a depth, and one superficial to draw the edges together and evert them. Needle passed from one edge to the other and again from lateral edge to the first and not tied. When needle is brought back from the second flap to the first, depth of penetration is more superficial. So just remember the far, near, and tie. This is how we perform the vertical mattress suture. It is very useful in GBR area. First point is at deep level of the buccal flap. And second point is a deep level of the lingual flap. And then third point is a superficial level of the lingual flap. You have to place the third and the last insertion point close to the incision margin. And the last point is a superficial level of the buccal flap. And make tie at the buccal side of your flap. Check the gingival margin everting. These are the examples of vertical mattress suture. Look at the first case. After a large amount of bone graft, barrier membrane was applied. Check these two vertical mattress suture. After that, the flap was everted and add some simple interrupted sutures. Look at the good adaptation of the flap without tension. And this is the second case at the low column. After GBR and membrane application, also the two vertical mattress suture were done, and additional simple interrupted suture were made. The flap adaptation was very excellent. Horizontal mattress suture is the strongest type of suture. This is used in large distances between the tissues, closure of the bone graft in implant sites. This can evert the much amount of flap in surgical area, but sometimes the depth of the vestibule can be very shallow. But this suture can leave a gap between flaps, so you have to add some simple interrupted suture along the flap margin. Horizontal mattress suture can be used for membrane stabilization and reduce the dead space. Insert a needle from the lingual flap. And then you have to do the periosteal suture, inner surface of the buccal flap. Pull the buccal flap outward and insert the needle at the periosteum. And then pierce the lingual flap again. Horizontal mattress suture can be used for membrane stabilization and reduce the dead space. It is very useful for membrane fixation. In this case, we make a note on the lingual side, but you can do the vice versa. You can make note on the buccal side too. If we see under the flap, the suture can push the membrane into the bone side. Personally, I usually apply the horizontal mattress suture to secure the barrier membrane for GBR under the flap every time I do the GBR. This suture can press the membrane that covers the grafted bone, so it can eliminate the dead space between the graft and membrane or underlying bone and graft materials. Figure of 8 suture pattern goes like this. This is usually used for extraction socket closure and also used for adaptation of gingiva papilla around the tooth and socket preservation technique. This suture induces rapid closure of the wound, but due to its orientation and direction, it is difficult to remove and it leaves a significant amount of suture thread inside the socket. And the other drawback of the figure of 8 suture is that this suture pulls the buccal and lingual side of flap too tightly. So after completion of the healing, the extraction site can shrink a lot. So to prevent this shrinkage, this is hidden X suture proposed by Dr. Park Jung-chul in Kyung University. This is conventional figure of 8 suture on the first one. The needle passes through over the extraction socket twice as if forming a continuous suture. A large crossed X is created over the socket after suturing. The blue arrows indicate the pulling vectors created by the X suture. Hidden X suture, the needle enters the buccal flap and passes to the opposite side in a diagonal direction. Then it passes again from the buccal to lingual side, also in a diagonal direction. A crossed X is created under the flap, unlike the X suture or crisscross suture. The blue arrows indicate the vectors created by the hidden X suture. These are the healing of the hidden X suture and X suture. In hidden X suture site, there is a minimum tension along the buccal-lingual axis, so there is a reduced loss of keratinized gingiva. And it can hold the graft or membrane in the extraction socket well. So this suture technique is very useful to do in the socket preservation cases. Suture removal is also important. Sutures should be removed using aseptic and stirrer technique. Step 1. Cleanse the area with an antiseptic such as hydrogen peroxide, chlorhexidine, or povidone. And step 2. Pick up one end of the suture with forceps and cut as close to the flap as possible where the suture enters the flap. And step 3. Gently pull the suture strand out through the side opposite the knot. The suture should be removed without pulling any portion that has been outside the flap back through the flap. At last, I want to introduce the new periodontal mucoadhesive dressing, Aura 8. A new mucoadhesive periodontal dressing called Aura 8 was developed. Aura 8 is a dressing system comprising a mucoadhesive layer and backing layer and provided attached to a thin film. The protection side is an outer surface of the dressing and to protect the wound area from the outside for 12 hours of contact duration. The attachment side is an inner surface that attaches to the gingiva. This part is attached to the wound for 12 hours of contact duration. The Aura 8 in extraction socket is very useful. The purpose of the Aura 8 in extraction socket is to stabilize the blood clot or graft material when socket preservation procedure is performed. Socket preservation is widely used procedure to prevent the ridge volume shrinkage after removal of tooth. In these days, we usually use open membrane technique and expect secondary healing over the grafted material. Excessive pulling of the buccal flap makes the vestibule shallow, so open membrane technique is more preferable. Ora-Aid, the mucoadhesive dressing, is easily used in these cases. After extraction, Ora-Aid over the grafted material and collagen membrane helps keeping the graft material stabilization. The Ora-Aid in extraction socket can be maintained well in position, but if you need to secure the Ora-Aid more firmly, suture can be used. In extraction site, after placement of bone graft, apply the Ora-Aid to the socket. Horizontal cross mattress suture, like this, can push the Ora-Aid toward the extraction socket and help the dressing stay in position. You don't have to suture the dressing directly. Horizontal mattress suture around the socket at the oral mucosa will be enough. And finally, I will show you the video how we use the Ora-Aid in extraction socket. First, remove the mandibular first molar by dissection the tooth. Remove each root first. And then trim the template first, according to the size of the extraction site. And check the trimmed template at the wound site. And then, for socket preservation, place the bone graft into the extraction socket. And pressure the socket site to remove the excessive blood or excessive graft material. And trim the Ora-Aid according to the template before we made. And remove the film and place the Ora-Aid to the extraction site. This is enough, but if you want to secure the Ora-Aid more firmly, we can do the horizontal cross mattress suture. Horizontal mattress suture can be used to secure the mucoadhesive dressing. You don't have to suture the dressing directly, just suture the oral mucosa around the dressing. I really hope that the fundamental surgical skills discussed today are very helpful in your daily practice. And if you have any questions or comments, please contact me at this email. Thank you for your attention.